Good afternoon. Thank you all so much for being here today. My name is Amy Bonnert. I'm a professor in the departments of anesthesiology, psychiatry, and epidemiology, and I am co-director of the U of M Opioid Research Institute. It is so encouraging to see so many of you here today, in person and virtually, to participate in a discussion about the ongoing opioid epidemic, where we have been, where we are, and where we are going. Earlier this year, we launched the Opioid Research Institute with a goal of connecting researchers across all disciplines and U of M campuses in an effort to save lives across the state and nation. This transdisciplinary institute, a partnership between the Medical School of Research and the Office of the Vice President for Research, brings together U of M experts and community partners to catalyze and expand high-impact research, programs, and partnerships that address opioid use, treatment, and prevention of developing opioid use disorders. We are excited to continue to host these and other events to reach these goals and to provide opportunities for faculty, staff, community members, and other organizations engaged in opioid-related research to learn more about the state of science in this field. I will now hand I'm not going to hand the microphone. I will step away and give Chad the microphone to my colleague and fellow Institute co-director, Dr. Chad Brummett, to introduce our guest today.
Good afternoon. It's good to see so many in person, and I know we have a number online, so pleasure to be here today. I'm Chad Brummett. I'm a professor of anesthesiology and one of the co-directors of the Opioid Research Institute, and I'm pleased to introduce our guest, my friend and colleague, Dr. Scott Weiner, today. Dr. Weiner has an extensive background in developing and implementing innovative ways to improve care for those in the need, for those with opioid-related harms. As an attending emergency physician and assistant clinical director in the Department of Emergency Medicine at the Brigham and Women's Hospital in Boston, Dr. Weiner's research and practice focus on technological advances in care. He also serves as the director of B-Corps, the Brigham Comprehensive Opioid Approach and Education Program, where he leads efforts to address issues around opioid prescribing and opioid addiction. Today, Dr. Weiner will discuss the past, present, and future of the opioid crisis and share his insights into steps we can take to address this critical issue. Dr. Weiner. Just before Dr. Weiner gets started, I will say I'm going to introduce as well. Afterwards, we're going to have another emergency medicine colleague, Dr. Keith Coker, here at the University of Michigan, who's going to join him as a part of the Q&A. Dr. Coker is an associate professor within the Departments of Emergency Medicine and Learning Health Sciences and is the director of the Michigan Emergency Department Improvement Collaborative, or MEDIC, at the University of Michigan. Many of you will know MEDIC. We have close collaborations for opioid-related work. Dr. Coker also serves as a research investigator in the Veterans Affairs for clinical management research. His work focuses on, amongst other things, emergency and acute trauma improvement and implementation of best practices. So, Dr. Coker, we look forward to hearing from you afterwards. And with that, Dr. Weiner.
Thank you all so much. It's so wonderful to be here. I'm so grateful for the opportunity. So many of you in this audience could actually give this talk. So I'm learning so much from you. I've really enjoyed meeting with many of you as well. When Chad came to speak at the Brigham, we basically just gave him a Zoom lecture and that was about it. And you've been much more gracious. So thank you so much for that. Before we get started, just a couple of disclosures. I served briefly on the acute pain committee for Vertex Pharmaceuticals, which is making a non-opioid pain medication. I work with Cessation Therapeutics, which is making an antifentanyl immunoglobulin, which we could talk about in the discussion if you'd like. And then I'm also employed by a group called Bicycle Health, which is the largest telehealth opioid use disorder treater in the country currently. I'm their research director. I have grants from NIH, Elevance Foundation, and then the Foundation for Opioid Response Efforts. So again, just really wanted to thank you. Just a little background. My son is a gymnast. He's a senior in high school right now. This is him working out in the U of M gym last summer. And he would love to come here. So if anybody has an in, please let me know. I'll do anything. but actually, I know you're big for football here, but your gymnastics is also incredible. You've got Fred Richards, who was in my son's gym just before he graduated 2 years ago, and he was named as the NCAA Gymnast of the Year as a freshman here at U of M. And we're hopeful that he'll make it to the Olympics this year, so in 2024. So keep an eye out for him. He's a U of M student. And then also, thank you for Open, and thank you for the Opioid Research Institute. Thank you for all this work, because we honestly, through the rest of the country, have learned so much from you and are really just in awe of the work that you've put together in Michigan. So thank you. I'm going to talk about the past, the present, and the future. And we'll throw in some Back to the Future themes in there as well, too. So the first, I just want to talk about my why I do this work. And for me, it relates back to my clinical work. Worked in the emergency department, been there for over 20 years now. And I wanted to just share briefly 2 cases with you. One is this case. It was a gentleman who was doing something you should never do in Boston, which is ride your bicycle. He was riding on the street, very classic scenario. Someone opened their car door, he hit the car door, flipped over like in a movie, landed on the ground, got back up and rode 2 miles to my hospital. I saw him, he had some left hip pain, and I said, all right, let's get an X-ray and we'll see what's happening. But that's not the patient I want to talk about. The patient I wanted to talk about is the one I saw immediately after him. And it was a gentleman that came in with shoulder pain. I felt like I had seen him before, but I couldn't confirm it. We had to pull medical records from paper at that point, so we didn't have it on the EHR. And he had scars on his shoulder. It's clearly he had surgery there before. And I said, okay, well, you've got some acute on chronic pain. We'll treat you with some Motrin and some Tylenol and a sling, and you'll be fine. He wasn't going to have it. He was there for oxycodone. There's no question. And we started to argue about it. And it hasn't happened very frequently in my career, but he really pushed my buttons, and we kind of got into it. It escalated. You're a bad doctor. I'm going to sue you. You're breaking your Hippocratic oath. Security called. He is escorted out of the ED. And there's no time to really gather yourself in the ED. We deal with that frequently. As Keith knows too, you might go from a code to then the next patient right away. You don't have a lot of time to process. I looked at the first patient's X-ray, and to this day, I still vividly remember this. I saw an X-ray and I called it normal, and I discharged the patient with crutches. I don't know if there are any non-clinicians here. I was going to call him Amy. Do you see anything wrong with this X-ray? Okay. Okay, a clinician, you can say. Yeah, it's a hip fracture. So it's got a femoral neck hip fracture right here. It's a big fracture. Luckily, several hours later, the radiologist called and said, I was already home, but he said, how come this patient was discharged? They've got a hip fracture. And he was called back immediately, had to go right to the operating room. And so I just use this to remind myself about the collateral. We've all got collateral, right? We've got friends and family, job productivity that's lost. There's all these things around opioids that, this patient will never even know that I missed this hip fracture because I was immediately arguing with a patient that was looking for opioids. So that was one case that got me involved in this. And the second, and I apologize for the graphic nature of the photos, but this is a nice spring day in Boston. There's a photographer for the Boston Herald, which is walking through the public garden. I don't know if you've ever been to Boston. There's the nice garden there. They're called the swan boats in the background. And there's these 3 gentlemen who are openly injecting heroin. And the photographer was really amazed by that and took pictures because of that. Shortly thereafter, this gentleman started to not look so well. He was kind of slumped over, stopped breathing. 911 was called. They ended up intubating the patient there in the park, started a code. And I happened to be on duty in the ED down the street. They brought me this patient. Despite over an hour working on him, we lost him. And I had to pronounce him dead, and I had to call his father. And I called his father and I said, I'm so sorry, we lost your son. We couldn't save him. He said, thank you for trying. I knew this day would come. He's the second of my 2 sons that were lost to overdose. And this affected me a lot because it was right at the time when my second son was born. And I just, we were talking about family at dinner and lunch. I just couldn't imagine something that could be so preventable that could actually take my boys, right? So we're very lucky. Again, one of them is a gymnast. One of them is a sophomore in college. They're doing well, but I'm still scared for them because now there are these pressed pills. There's so much stuff out there. So this is my why. So I'm sorry to take so much time for that, but I wanted to just explain that to you. I'm going to talk about the past. Those of us have been doing these for a long time, doing opioid work for a long time, know these maps. They used to show us the opioid-related drug overdose deaths per 100,000 population. And back in 1999, there were a couple of hot spots. And then as soon as we hit 2014, the whole country was red. And to that point, this is Ann Arbor, so I'm just going to say I'm fortunate that this is not a political map, but basically we stopped looking at these maps because it was senseless. It was in every community, everywhere. There's a lot of places we can try and place blame. Some people want to place blame on the Joint Commission. There was actually an interesting thing that came out several years ago where the chair of the Joint Commission came out and said, we never said pain was the vital sign, even though it's in their literature. That we never told you to treat pain with opioids. We just said pay attention to pain. There's really this cognitive dissonance that I've actually used with my children to show this is an example of how you did not take responsibility for something that you helped contribute to. And of course, there's this OxyContin, and we were just talking about Painkiller. I don't know if anybody's seen that on Netflix, or Dope Sick. There's also the book by Barry Meyer called Painkiller. And this whole phenomenon with OxyContin is just really intriguing to me. The demand just wasn't there before this came out, right? I mean, there were people that were using heroin. Keith and I, we've probably seen patients that use heroin ever since we started training, but it was never to this level until OxyContin and oxycodone started being used more frequently. It just primed the pump for demand. And you could see that in the prescriptions. And this is billions of milligrams of morphine milligram equivalents that were dispensed. So we increased basically tenfold from 1992 to 2011. 240 billion milligram equivalents, just this massive amount that we dumped on our population. So this is where I think our game of whack-a-mole started. And our first whack-a-mole was for opiate prescriptions. We had to get the prescriptions under control. And the first step to that was for PDMP, Prescription Drug Monitoring Program. And again, I'm just going to talk about the past briefly. Ohio was one of the first states that had an electronic PDMP that allowed providers to see the prescriptions that were dispensed. Other states had them, but they didn't show the prescriber at the time of a new prescription. But Ohio was one of the first. And I was just so amazed. I was thinking back to the patient that had the shoulder surgery, thinking like, if I had known where else he would been and what prescriptions he got, I might have known that he was looking for a prescription. The study in Ohio, they showed the doctors their data from the PDMP, and it changed their management in 41% of the time. Like, this is incredible. Like, we should all have this. And so I really advocated hard in Massachusetts. And we were lucky that a couple years later, we got our own PDMP. And being like an academic nerd, like a lot of you are, I'm like, okay, now we're going to study it. So we looked at, we did the same thing, but instead of just looking at if it changed management, we actually asked the physician before they saw the patient if they thought that they were drug seeking. Now, I would never use that word in a research study today. It's stigmatizing. There's not an objective definition for that, but this is what we did at the time. And we found that overall, the positive predictive value of emergency physicians for detecting this behavior of seeking multiple prescriptions from multiple prescribers was really low. So it made the case that we really should have the PDMP. Eventually, most of us got PDMPs. Missouri was a little bit late, but a lot of us got PDMPs. And I always thought, like, if they build it, they will come. I was so impassioned about this. I thought it was useful, but people were not using it. There were a lot of reasons for that, and some of this has to be around there was not integration with the electronic medical record. It was difficult to find the website. It was this complicated URL to get to it. Didn't rely on the same password as the hospital. Didn't update routinely. It was frequently down at night when I was working in the ED when I needed the data the most. So we published a lot of papers around that and criticizing that. And fortunately, it's gotten much, much better. For U of M, do you actually have PDMP integration? Yeah, it's like, what's that? It's fantastic. And we actually published a study on this as well too, where we looked at, after we did an implementation, we were able to increase the searches by 40%, and it was across nearly every specialty. Right now, we just push the button and we get our PDMP response within 5 to 8 seconds, and it queries all the neighboring states with Massachusetts as well. So it's been really, really helpful. But again, PDMP is like helpful for one patient at a time, but it's also extremely helpful for public health and to learn about epidemiology of prescriptions. And so that was the next thing we did. We started to work on looking at reports from PDMP. I was very fortunate to work with Chad Garner, who's the PDMP administrator in Ohio, very forward thinking about use of data, and basically gave us de-identified data, which was fantastic. And we could start to do some interesting studies. The first one was we wanted to look at the prescriptions by specialty because EM always gets a bad rap, but we had a lot of blame. People thought that the majority of prescriptions were coming from the ED. Actually, it turned out that it was fairly low. It was only about 5% of prescriptions. And then only about 1% of the MMEs were coming from the ED. So pretty low. And I always like to pick on anesthesiologists. They also had about 5%, but they had 11% of the MMEs. That makes sense, right? Because they're managing patients in pain clinics. And at the time, it was all about opioids in the pain clinic. But the lion's share was actually coming from family medicine and internal medicine, which was fairly interesting. The next thing we did was we started to apply it to policy. And we did, which since has become my favorite analysis tool, which is the interrupted time series analysis. You can look at secular trends, and then you can see an intervention, and you can see if things change afterwards. There were opioid prescribing guidelines for emergency physicians in Ohio, and you can see that there was already a downward trend. The policy is implemented, and then the downward trend slope gets greater. And it's actually pretty staggering that the decrease in prescriptions between this time, between 2010 and 14, went from 60,000 all the way down to 30,000. It went by half. So like Stefan and I were talking about this earlier about this peak and how quickly it dropped our utilization of opioids. This is another kind of curious one we thought was interesting. If you recall, the DEA rescheduled hydrocodone at one point. It used to be a Schedule 2, then it went to Schedule 3. And we looked at it and we found that sure enough, the slope went down a little bit, but as soon as it went down, codeine went way up. So it indicated that temporarily, at least, people were substituting codeine for hydrocodone. But kind of just, these are kind of novel, neat, fun ways to look at PDMP data. This is why we did it. But as we know, the problem is that PDMP just tells you a patient and a prescription. It doesn't tell you why they had the prescription. It doesn't tell you what happened afterwards. It doesn't tell you their condition. And so there's really something missing by just using PDMP data. So now we're going to fast forward. We're going to be around 2017. Opiate prescriptions are starting to fall. We've been at our peak. Now it's about 170 billion milligrams dispensed. And what's happening with overdose deaths? Yeah, they're shooting up, and markedly too. So this is around the same time. You can just see they just markedly shot up. So we were fortunate in our state, and I wanted to spend some time on this because I know Chad had expressed some interest, and hopefully this is helpful. In Massachusetts, there was a law that was passed to try and figure this out. Say, okay, we've cut back on these opiate prescriptions, but death is increasing. Why is this? And we said, well, there's all these other factors that we don't know yet. So they passed a law that's called Chapter 55. And it's basically took the all-payer claims data set as the spine, and that had patient name, date of birth, just some basic demographics. And then it pulled in all these other data sources. It included the PDMP. It included what we call BSAS treatment, which are substance use disorder treatment episodes. Matrix is our ambulance pre-hospital data set, birth records, death records, hospital and ED. And just based off the colors, you can tell this is very similar to other states too. This data is held in all different areas. The data was not put together initially. But for the first time, we were able to merge the data, which was really powerful. And I wanted to ask a question. And that question is familiar to those of us that work in the emergency department, which is, I was seeing patients that had an overdose. Usually they got Narcan. We would park them in the hallway. If they were lucky, they got an O2 sat monitor. We'd wait for them to wake up. And as soon as they were awake enough, we would discharge them, usually with a piece of paper that had a list of detox facilities that was photocopied and then refotocopied and then refotocopied. And I thought that was very wrong. Completely futile, right? Like I know that the patient was never going to call those numbers, and if they did, there wouldn't be appointments. So I wanted to know, what would be the chance that that patient I discharged would be dead in a year? Are there any guesses? 10%? No. Any other guesses? It's like Price is Right. You want to go over? No, I'm just kidding. No, it's actually, it's a pretty good guess. It's 5.5% was the number that we found. a little bit lower than what you expected, but still like kind of high. The average age was in the 30s for these patients. They typically don't have other comorbidities. It's actually really surprisingly high that 1 in 20 would be dead in a year. Now, this is a similar mortality to what we see for patients that go to the cath lab for an acute MI. So it's really high. We also found that about 20% were homeless. The other thing we found is that even though 5.5% died in a year, about 1 in 5 died within a month. And then of those, the big peak was just 2 days after the ED visit. So we were losing people that we were discharging right from the ED. Really makes the case that we needed to step up our game. So about this time too, this RFA came out through with NIDA. If you're not familiar with this one, it's a good mechanism. They've renewed it several times, including very recently, and it's just using pre-existing data. And we were talking earlier before, I was able to pair with a group that's in Oregon called CoMagine, and we put together a proposal and we had that funded. And the proposal was very simple. It was to do very similar to what we did in Oregon, but in Massachusetts, but do it in Oregon where we had access to this data. And we wanted to know, what are the individual risk factors for someone that gets a first prescription, completely opioid naive, they get a first prescription, what would then put them at increased risk for having subsequent overdose? And then, because we have this data, we're like, well, let's look at the household level. And so what is the risk if someone in the household has it? Like someone gets a prescription for a surgery and then there's someone else that's in the household. Are they at increased risk? And then finally, we wanted to look at community level risk as well. How about MME availability for the community, or even the characteristics of the community? Does that environment affect your overdose risk? So we were able to work with Oregon on this we call comprehensive opioid risk registry. Very similar to Massachusetts, we took all payer claims data, we pulled in census data, we pulled in vital stats, hospital discharge, PDMP, and EMS. And I apologize in advance for the next slide, but I know that a lot of you are working on this kind of data and we're interested in how this happened. So I'll go into a little granular data about how we did it just to meet the requirements that we had in Oregon, which might be similar to Michigan, actually. So first, we had the all payer claims data set. We had this already. You can often purchase these from states or insurers. So we had that data. We created a unique study ID that was just randomly generated. And we passed this over to the state. We said, this is our identifier, this is our key, this is how we'll identify patients down the road. We then took the all payer claims data set, we added in the EMS data. The reason for this is that sometimes patients get treated by ambulance. The ambulance is called for overdose, and then the patient leaves. And so we don't actually get there, we can't capture that visit in the hospital because they never presented to the hospital, but we still wanted to capture the overdose. We then pulled in vital records, death certificates, and then we pulled in census indicators for the community. We called that our enhanced APCD. We then pulled in hospital discharges. And then we removed all the identifiers except for that randomly generated identifier we created before. And then at that point, we fed it to the state. We had to delete any connection we had. And then because PDMP, like in most states in Oregon, is very tightly regulated even by legislation, only at that point could they bring in the PDMP data. And then that created what we called our PDMP data table, merged with our minimally necessary APCD. And then that became our core data set. Oh my gosh, this took 2 years. It was just, the grant was 5 years, it took 2 years. And since then we've refreshed it. It was a lot quicker because we already had the experience, but these are the kind of administrative hoops we need to go through to use this data. So does this resonate? Yeah. Yeah, so I have one more thing. Whoops. We said few at the end because then we could use the data. The nice thing about this is that once we had the data, different than Massachusetts, we could just do whatever analysis we wanted with it, which is really powerful. I'm just going to quickly go through the aims, what we found. Aim 1, again, was those individual risk factors. We surprisingly found that individuals who were over 75 were at a higher risk. This was novel. And the reason that I think it was novel was that studies often look at overdose risk based on opioids by age, but we were able to confirm by PDMP data that they were opioid naive. So if you start an individual who's over 75, who's opioid naive on an opioid, they have a much greater risk of having subsequent overdose. We also found some things that are not surprising. Dually insured is a very high risk. Medicaid versus commercial is an almost 4 times adjusted hazard ratio. And then interestingly, and this is like kind of resonates with lunch, we talked about lunch, but tramadol versus codeine also had an increased risk of overdose. This was the bonus paper we were also talking about early. I was really curious because, like, what do you guys prescribe for opioids in the ED here? Are you hydrocodone or oxycodone? Right. Oxy, yeah. I mean, it's very geographically different. Some states love their Norco. They prescribe a lot of hydrocodone. Some states are all oxycodone. Some people think that it's better to use the combination product, like the oxycodone with acetaminophen or Percocet. Some people think it's better to separate them, so you can take acetaminophen and then add on oxycodone on top of that. So we were really curious to see what we'd find from our data. And we found that those that had, well, first of all, it was 2.8% of the individuals had chronic use and 0.3% experienced overdose. So not huge numbers, but still there. And then we found that if you got oxycodone, you had a higher risk of having an overdose. But if you had hydrocodone, you had a lower risk of developing chronic use. And then also, interestingly, the monotherapy had over 2 times adjusted hazard ratio of having overdose. So we thought this was very interesting. It's hard to tell exactly the meaning. It could have been that the intent was to treat the patients with hydrocodone long-term. But this did give me pause because I think people think of these medications as equivalent, and I'm not entirely convinced. And then finally, to the household risk, we basically compare with the reference group, which would be considered 1 for a risk. If you had a household fill only, your risk increased to 1.6. Actually pretty impressive, right? This is the medicine that's just sitting in the medicine cabinet, increases the risk of someone else in the household having an overdose. If you had your own fill, it was a 5-time greater risk compared to if some individuals without a fill. And if you had household fills and your own fill, the risk was 6 times. Really makes the case that we needed to instruct patients about safe storage of the medicine, getting rid of the opioid take-back box, whatever, as soon as they're done with it. And then finally, for community, we looked at the social vulnerability index, which is different classifications about communities. And we found, interestingly, that the morphine milligram equivalent content in the community didn't really matter. But we did find that some of these other factors did. So higher housing insecurity, lack of transportation, and higher OUD per capita, which makes sense, is attributed with a higher rate of overdose. And then there were some protective factors too. Communities with more elderly and youth, with disability. Interestingly, single-parent households, with communities with higher single-parent households had a lower risk. And then lower English proficiency also did too. So our paper doesn't explain why this is, but we found that these were kind of interesting factors. And this will be coming out, we're in revisions right now, should be coming out soon. Okay, so now's the part I get to have some fun. All right, so fast forward, I showed IQVIA data for you. You can see that we've markedly decreased our opioid prescriptions. Back in 2020, we're like, kind of to where we were back in 2000. The pendulum has totally swung. And of course, what we're seeing is that the deaths just keep going up. We know there was initially this rise from prescriptions, then there was a brief heroin, and then synthetic, so fentanyl. And now they say there's the 4th wave, which is stimulants plus fentanyl, combination drugs. So again, we're playing this game of, again, what I think is whack-a-mole. We're just trying to fix it. First, we're trying to fix the prescription opioids. We then try to address heroin. Now we have to address fentanyl. And so again, this is the part where I get to prognosticate a little bit, and hopefully we can have a discussion during our panel afterwards too. Hopefully I won't go too far off the rails. I'm just going to throw some random thoughts that entered my brain and dump them on you. So, but first of all, if I'm going to talk about the future, I have to talk about AI, right? So we were talking about it at lunch too. So first of all, ChatGPT, I just wanted to talk about my thoughts briefly with that. First of all, it's terrible at telling jokes. So I asked it, tell me a joke about opioids. And it said, why did the opioid refuse to play hide and seek? Because it didn't want to be concealed from its pain. And I wrote back, I said, that's not funny. And it said, I apologize that it didn't meet your expectations. Let's try another one. Why did the computer go to rehab? It had too many bites of opioids. It's not funny, right? So my job is telling dad jokes is safe. So at least they're not, the overlords are not taking over yet. But we did have a study recently. Well, so there was a study from Valencia, Spain, that was very similar to the study that I showed you before that we did in Oregon that looked at risk factors of overdose after a first prescription. And their findings were, some of them were similar, like the benzo opioid combination is dangerous in both, but others were completely different. The age risk was very different. The individual medication, like whether tramadol or codeine, was very different. And so we put this editorial together because eventually the AI will be trained on these studies. And what does it do when there's disparate results? And what does it do when it doesn't know the population? Right? There are some inherent differences in this population between Valencia, Spain, and Oregon that have to do with other social determinants that we don't capture. So I'm really nervous about that for AI. It also can propagate race-based medicine, and also mentioned before too, there's a possibility it could perpetuate stigma. If there's stigma in medical records, then that can also be perpetuated with AI. So just something to keep an eye out. I think we have to be really good about being the stewards and the experts that inform that process. I'm hopeful we're going to have better data harmonization. This is actually from that DALL-E, which is AI generated. I asked it to show me an oil painting of better data harmonization. This is what it came up with. Maybe not museum quality, but decent. I'm hopeful. We need better data. We need our states to start talking to each other. It's it's good if we have Michigan or Oregon or Massachusetts, but we're missing large swaths of the population by not merging that data together. The part that really that I'm not sure about for the future that really worries me is what will happen next. This paper was just in JAMA Open a couple weeks ago. So we know about fentanyl and we know about analogs of fentanyl, but now they're increasingly seeing this class. It's called the nitazene class. It's not structurally related to fentanyl, but it's got equal potency. It's like 1,000 times more than morphine. The way that this is happening right now is we're just going to keep seeing these drugs. And Chad and I were at the National RX Summit last April, and the reason I like that conference is it's very multidisciplinary. One of the speakers that I went to was a DEA law enforcement agent, and he was talking about the drugs coming through the southern border. And he said that in this border in San Ysidro and San Diego, they have about 21 million crossings per year. They have the bandwidth to search 1% of cars and trucks that go through. Said if we did more than that, we would shut down international commerce. There's no way that they can stop this. And the DEA agent basically said in this conference, this is up to you because we can't stop these drugs from coming in the country. So I think we need to acknowledge that. We need to say, look, they're here. There's no way we're going to stop it from entering our borders. And I hate to be pessimistic about that. We can build a wall, we can do whatever, but I don't think we're going to stop it from coming in. And we have to deal with this new normal where it is there. Now, I asked this question to be provocative, but I said, marijuana is legal in many states now. What has happened to seizures of marijuana at the border? Nothing. It's plummeted. There is no market for illicitly grown marijuana anymore because it's all being grown domestically. And that makes you think, right? Maybe we should do the same thing with opioids. I don't know. I'll tell you that, my son, the gymnast, and I, this was a couple weeks ago, I had a donated supply of Narcan that was expiring in November. We know that it lasts longer than that, but I couldn't get hospitals to take it because it was expiring soon. I said, let's just go to the area of Boston. It's called Mass and Cass, where there's a lot of drug use going on. And I saw probably one of the toughest scenes I've ever seen in my life. Just hundreds of people in tents, most actively injecting or just passed out. They were very grateful. We passed out the 100 kits in like an hour, but this is hard. And I hope we can get to the solution here, because I don't know what the solution is here. We can offer treatment, we can, but anyways, I think what we need to do is really focus on, go back to our public health skills, go back to these principles of prevention. And I'm going to start with kind of tertiary, secondary, and primary. If you recall, tertiary is basically just keeping people alive. So we should have Narcan everywhere. We should give out safe injection and inhalation supplies. It's if anybody thinks that we're going to be encouraging people from using drugs by handing them out, I think that they're sorely mistaken. I think that we're only going to be encouraging them not to get HIV and Hep C. Yes, test strips, right? Why not? We're seeing this big increase we're seeing from this fourth wave are individuals that were using stimulants and not dying. And now it's adulterated with fentanyl and they're dying. So let them test. Safe consumption sites. I'm a big proponent. I would have never said that years ago, but now it's like people are going to use. Let's keep them alive. My good buddy Don Stater, who's in the Naloxone Project, says that naloxone is the recovery drug. Is the gateway drug to recovery. You can't have someone in recovery if you don't save their life. I think we should decriminalize possession, and I think that we should really push housing first and get people there, not make them be sober, not make them be in recovery, get them housed first. We're making some progress. This was a project that we were able to get some funding in Massachusetts for. We found that there are these hotspots where about 1 in 10 of the opioid overdoses in Cambridge happened at 5 of our subway stations, the T stations. So we actually were able to get some funding through the work of some Harvard undergraduate students who convinced the legislator to put this in the budget, to put naloxone on all the platforms in the Red Line in Boston. So we'll be doing that soon. Again, random thoughts. This was in Harvard Public Health. Overdose rates doubled in neighborhoods following police raids. Disruptions to safer drug supply lines can play a role. Decriminalizing opioids will save countless lives. But yet I saw this news in the New York Times not too long ago. They're going to shut down the overdose prevention sites in New York City, where they've reversed over 1,000 overdoses. Don't understand. And this scared me even more. So the fentanyl problem has really been localized to North America for a very long time. And I think that the reason is that a lot of the rest of the world gets its supply of heroin. And you can still obviously overdose on heroin, but it's not nearly to the effect that we're seeing with fentanyl. And this article came out in Time not too long ago. So the Taliban in Afghanistan are suppressing opium production. And there were 2 lines in this article that really made me pause. The first is that the Mexican cartels, the key traffickers of fentanyl in North America, have developed new smuggling and retail networks, as well as synthetic drug production hubs in Western Europe. Either way, it's clear that cutting off the supply doesn't end use. It just forces those with substance use disorder without treatment to switch to more dangerous drugs or new suppliers. On that thought, secondary prevention. Let's treat people who have opioid use disorder. This is a study from the ED at Yale many years ago. They found that if you give people Suboxone and you give them rapid follow-up, you can double their 30-day retention in treatment. It's like there's nothing in medicine that has results like this. But yet we have difficulty now at the pharmacy level to have them fill prescriptions for buprenorphine. So I also do work with Bicycle Health, again, telehealth. It's so bad that when we get a new patient, we call their preferred pharmacy to confirm that they have stock before we send the prescription. Because the worst case scenario would be a new patient that's starting to get on Suboxone, and then they go through withdrawal because they can't find the medicine, and then they relapse. But could you imagine if, like I told you, your endocrine clinic had to call every pharmacy for every patient for their insulin? It's just bonkers. And I think that the reason this is happening, and I do want to play, I want to be adversarial towards the DEA, because I think that they're treating buprenorphine similar to all the other controlled substances. It is a controlled substance. It needs to be treated in a special way, but it shouldn't be treated on the same level as OxyContin. So we're hearing from pharmacies that there's this massive amount of paperwork they have to fill out. We're hearing that the reimbursement from the pharmacy benefit managers sometimes doesn't even cover the cost of the medicine. And it's really, we're playing whack-a-mole with the wrong mole, is in my opinion. So I'm hopeful that we can change this. This is Nora Volkov. You all know her. She's the director of NIDA. She actually responded to that study. She was interviewed and said, for someone with an OUD to go through the process of deciding to seek treatment, meeting with a healthcare provider, and getting a prescription only to be turned away by the pharmacy that does not stock the medicine they need is cold-hearted, unethical, and inexcusable. This must change. And yeah, invoke Phoebe for a second. Stop the madness. There is some hope, and I think this is where we come in. This paper, some of the investigators you might know, like Mark LaRochelle, who's at BMC, they did a simulation. And they said, what if we can increase MOUD initiation fivefold? What if we increase MOUD retention rates? And what if we increase naloxone distribution, as you're all working on? And then what if we further safe opioid prescribing? Further models at 5 years, you could reduce ODs by up to 46%. It's just a theoretical model, but it is evidence-based, and I think this is what we have to keep pushing for. And then finally is this primary prevention, and this is the hard work, and this is the part that I feel like we so rarely talk about, but we need to figure out community-based programs could take preventing adverse childhood events, if that's even possible, but doing our best to do that, to stop people from wanting to use them in the first place, because again, they're in the community, they will be used. I saw this recently, this was on August 31st. Biden administration's releasing $450 million to fund this. It's $20 million for 164 drug-free community support programs. There's some work for treatment, prevention, which is good. But I don't want to knock the administration, I'd rather this than nothing, but doesn't it feel like a drop in the bucket? I mean, for the whole country, we're going to give 20 million to 164 community centers. Like, what can you do with that? So I'm hopeful that we can lobby. And that's where this is the end of my talk, which is that I want to just challenge all of us. I think that we have the expertise, we have the data, we have the knowledge, we can be very persuasive with policy. I think we have the capability to move the needle. It's just, again, we have to do that hard work. So thank you for your attention. I hope this was useful. I'm, again, so honored to be here, and I'm looking forward to a good discussion.
Thank you so much for that stimulating discussion. A lot to react to there. Maybe I'll just start with a broad question. You've worked on a lot of different aspects of this problem. What has felt like the greatest win to you in terms of something that was even more successful than you anticipated? And if you're not feeling in a positive mood today, I could also ask, what's been the greatest disappointment of something that you thought would make a big difference and didn't as much as you hoped?
Amy, I'm an optimist, so I'm going to talk. I'll take what I think is helpful. And by far, it's I think it's the work we're doing in the ED. Again, I mentioned that patient we used to park in the hallway, and then would just discharge with a detox list, and I think that was leading to burnout, because we felt as clinicians defeatists that we couldn't help these patients, and now we have an ability to help them. So, like in my hospital, we set up a bridge clinic. It's just down the hall from the ED. We can start them on buprenorphine in the ED. We can send them there same day or next business day, and we do see positive response. But my disappointment from that is that we don't have as many patients as we expected. We want now, so it's completely flipped. It used to be, oh no, another overdose patient. Now it's like, where are my overdose patients? I want to get them I want to get them in treatment. I want to start them on medication. I want to get them into treatment. So, but I think that just talking about that has really modified the approach towards patients. It's really worked for stigma, because again, I think the stigma amongst healthcare providers was based upon the fact that we felt helpless. Now that we feel like, yeah, we can help people. This is someone's son or daughter. That feels like a win. Mm-hmm.
No, I mean, my perspective is very much centered in the emergency department as well, and I feel that change too. As I reflect back on some of the work we've been doing around harm reduction across the state of Michigan, we started around 2019, 2020. It felt like a hard case to be made. There was some negative reception to the message around the impetus and rationale around harm reduction in the emergency department. To be honest, like that study that you did, Scott, was truly motivating around like, here's a case to be made that we have a tool that can reduce mortality for those that are our patients. And when I reflect about how these conversations go now, it's very different. And that's, I think, a general sort of outside experience, not just like in the academic centers too, but sort of across, I think, the swath of emergency departments and care providers there, and really like the entire care team too. So I agree there's a sense that there's a change in reduction in sort of the stigma that's associated with that for sure.
So I want to also open the floor to others asking questions, and Kate's also going to field some online questions. If anybody is ready with a question, if you want to raise your hand, we can bring you a microphone. But if folks are gathering their thoughts, can we have one here?
I think this is working.
Oh, perfect. Thank you very much. I really appreciated your sort of primary, secondary, tertiary approach to thinking about this. And it reminds me a little bit of kind of like war on cancer, which is, you know, for a long time that everyone was hoping there was going to be a magic solution, one giant mole to shoot. And in some ways, I think you never hear oncologists talking about cancer like that anymore. And I think your approach, which is like acknowledging that it's super complex, that there's not going to be a single kind of solution, and that it really requires this really broad look at the whole spectrum, is, I think, very valuable to the field. And so if you had to pick where you think we should focus our energy now, though, acknowledging the fact that there's no simple solution, where do you think we should be focusing our efforts in terms of both data and then on the practical side?
Thanks for the incredible question. You mentioned cancer. We had the cancer moonshot, right? And no one bats an eyelid. It's just like, of course we're going to do that. Everyone wants to fix this. Why don't we have an addiction moonshot? And I actually think it's more achievable, because again, this has to do with things that we can change in our society that are modifiable. And it has to do with so much: housing security, food security, job security, things that are, if we've addressed them up front, would be so much more cost effective than waiting until we're picking up the pieces later on. So, excuse me, sorry, I don't, as I age, I feel more and more skeptical that this is going to happen, but I would really love for us to be introspective about our society and really say, why is this happening? What's encouraging people to want to use drugs, and cut that off at the pass. And there's programs like other countries. I think it's Finland or Iceland, something like that, has a program that's mandatory after school. They have a program, get all the kids into the sports, other activities. Maybe it's something like that. Like let's start some pilots like this to see how that works. I put up YMCA, Boys and Girls, but like I'm not endorsing any of those, but like that kind of thing. We need the structure of our society to modify to protect our society. How that's done is, of course, really controversial and politically charged, unfortunately, but that's where I would love to see us go.
No, I mean, that's really inspirational. I mean, I was like, well, how do you respond to that kind of question? But I mean, I like this idea of like, if you're solving the root causes of social determinants of health, you're probably additionally solving these kind of challenges too.
Yeah, I'm going to use MC privilege to add my thought, which is, I don't think we invest nearly enough in prevention with youth. And, pretty much in every topic you look at, your greatest return on investment is when you invest early in that first level of prevention. And there's the benefit of, what prevents substance use, prevents depression, prevents engagement in violence, and all of those things. So, sorry, next question.
Hello, my name's Jacob Rich. I'm a PhD student at the Cleveland Clinic. And I'm curious, right now, where are we in terms of opioid use disorder and addiction relative to the last 20 years? And how does that relate to the opioid overdose death rate?
Another great question. Do you want to take it first?
No, go for it.
So I think where we're at is a newer recognition that this is important to treat. Yesterday we were talking about conferences, and it used to be some of these conferences, like the Immersa conference, would be for addiction. They were begging people to come. Now you can't even get in; they're totally full. So I think that there's this recognition in the House of Medicine that this is a moment, this is something we have to do. And the thing that encourages me even more about is how multidisciplinary and how multi-specialty it is as well. We're emergency physicians, but there's anesthesiologists, primary care, internal medicine, pediatricians, like everyone is working on this now, which makes me really makes me reassured. The question is, where would we be if we didn't have that? Like right now, we just see this terrible news every year about these overdose deaths increasing. But where would we be if we didn't have this extra layer of treatment? Where would we be if we didn't dispense Narcan as much as we're doing? Where would we be if we weren't as responsible with our opiate prescribing? And that's the part I don't know. I mean, my hope is that we're helping it. We're making a dent. Hopefully, the curve will get better because we're increasing access to treatment. But it's hard to know because we don't know what the absence would be. I don't know if that answers your question or.
Just real quick, just the prevalence of OUD and addiction, is it like lower or higher right now relative to the last 20 years? Do we happen to know that, or are those data not good?
Can I jump in?
Yeah, I was going to ask you.
It's nice to see you. It's been a while, so thank you for joining us. I think not good is the short answer. The National Household Survey on Drug Use and Health has a lot of problems with measuring this well. I'm very interested in the methods that have been coming out of Colombia that you're probably aware of as well, where they're taking an approach to inferring the OUD rate from the overdose rates. Obviously, those are tied, but the way they are accounting for the fact that the conditional risk of overdose given use has increased as fentanyl has taken over, their estimate is that OUD is declining in the US and has been for the last few years. Sorry if that was a little disruptive.
Perfect. Yeah.
Hi, I'm Rob. I want to take advantage of two things you said during your presentation. One was the about $20 million recently being dedicated to this crisis and what a small amount that is. And the other thing that you said is you're an optimist. So I'm looking forward to this response. When you think about only $20 million for such a tremendous problem, and also you add to that, this wealth of settlement dollars that have, depending on the state you live in, either no accountability requirements or very soft accountability requirements for how that money is used and whether or not there's any evaluations of programs that work more or less. I wonder how you maintain that optimism and what it is that, this is a room full of scientists, clinicians, and mix of people. Is this something that we just have to solve ourselves without that kind of support? Or like, how can we, how can we bend that to our advantage if it's possible?
It's really my question to you. And that's why I'm optimistic, because you're all in the room and you're all smart. Seriously, I mean, I think we don't know, right? I mean, how much of our work is on this primary prevention, looking at effectiveness of these programs? It's probably not a lot. We probably could spend more time focusing on that. I think I'm optimistic because I have to be, because otherwise it's just, why are we doing what we're doing? That's the question. I don't have the answer. I don't know if you have a thought on this too, but it's just.
I mean, with settlement dollars, you have opportunity too. Maybe there are uncertainties about how that gets distributed, the accountability around that, but there's also, as you said, like opportunity and to influence where those monies get spent too. But I don't have any answers either.
And someone back there had an answer.
Yeah, I have a question. I've been hearing a lot recently about muscle rigidity that is caused by fentanyl and that contributing to mortality because trouble intubating and just breathing in general. So I was wondering, from your perspective, how often you encounter muscle rigidity as a problem, and if you have any data on how frequently it's occurring.
I haven't seen it, and I don't know if it's because the people that have it die before they reach us, but I'm not seeing it in the ED.
Yeah, I can't say I've clinically experienced it either.
Maybe Chad
has.
He's in the order.
I know you and John have been talking about this, right? Like it's an interesting concept. The only time I've seen it is in the operating room giving incredibly high doses for induction for cardiac surgery. I don't know if you've ever experienced that, Mark, but I've seen chest wall rigidity, but the reality is that it's very fixable, right? Like, so it doesn't last forever. And now maybe it's because we induce a full anesthetic to follow, and that might be a difference from what's seen in the field. But I guess I could see if you were using a really high dose of fentanyl alone and the EMS people were not, attuned to the fact that you can get that skeletal muscle rigidity. It's not that you can't breathe past it. It's just, it's tough. I don't know. But I've only seen it. I've only seen it a couple of times. I don't know about you, Mark. You've seen it or Stefan? Just a few times. So they do more anesthesia than I do, and they still don't see. But for a standard like operating room anesthetic, you'll almost never see it. It's only with really high doses, which really aren't in vogue anymore, like they were for a long. I have less hair than they do, and so they probably didn't even have the same doses of fentanyl for their induction of cardiac surgery. So I guess I can see. I mean, some of these doses of fentanyl in the community are getting pretty high. So maybe. Do you have a pharmacologic?
Yeah, what was the reason for the question?
What's the fix?
Didn't need to be so long-winded. But alpha-2 agonists can reverse the muscle rigidity, at least according to some of the older literature. And xylazine, which is an alpha-2 agonist, is being mixed more with fentanyl, but yet that's increasing overdose rates and not decreasing it. So that's makes me think muscle rigidity isn't a contributing factor, but I don't have any data on that. It's just what I pieced together.
Yeah, I feel like increasingly we're flying blind with data because we don't know what's happening out there, and we're especially with naloxone being dispensed so frequently, we have no way of knowing when it's used, how many overdoses are actually occurring, how many are being reversed. It's really hard for us to do data scientists, right? Because you don't really know. We don't know what dose people are using. We don't know the potency. We don't know exactly what they're doing. I showed you that one study that found that the nitazene class that did have, they tested that when a blood sample was sent from the ED after overdose, but we often don't send blood after an overdose. So, and people are often shocked to hear that. Sometimes we don't even do a urine toxicology test because it doesn't change our management in any way. But so the patients in that study were those that were the sicker ones that probably were admitted, they actually had a blood sample, but the surveillance is really tough.
Scott, would there be any way to pick up on any of that in these kind of massively linked data sets, or is that like too nuanced of a thing to measure for?
I think there's some work around using drug seizure data as well, because you get a better idea of what is happening in the community. That's probably the best one I've heard. And if you have other suggestions or.
So there was a question about the prevalence of OUD that I wanted to follow up. I guess I feel like there's, at least in my head, there's a little bit of a confusion as to how much of the recent rise in opioid overdose deaths is related to opioid use disorder per se versus accidental exposure to fentanyl. And this seems like a really critical question, given that the policy solutions would be extremely different, right? If it's opioid use disorder, then it's more buprenorphine, right? And if it's people accidentally just getting, exposed to something, a college student trying a fake Percocet or something like that, then it's primary prevention. It's like counseling about don't do drugs. And in some ways, that's a little bit harder to wrap your head around because it doesn't feel like it's a little harder to say me talking to an adolescent or a college student about doing drugs, that's the solution to the problem as opposed to giving more buprenorphine. You know what I mean? Like, so I guess it's just a general question about, do we have really good data? Or do we have any sense of to what degree opioid overdose deaths are being driven by opioid use disorder specifically? And if we don't, how do we get that knowledge?
Yeah, my sense is that we don't have that good data. I think that we see certain outbreaks when there's pressed pills that are, teenagers might use at a party, and then we see a large number that overdose during that episode, but I think that's more sporadic. I think that the majority, at least in my opinion, would be that it's patients with opioid use disorder. And then the corollary to that we often don't consider is that, sometimes the overdose is actually a suicide attempt, and there's concurrent depression as well. We often don't consider that or think about the depression as the underlying problem as opposed to a substance use disorder. But to your question about data, again, I turn it back to you. I don't know how to capture that because, especially if someone is deceased, it's hard to ask what happened. I don't know if we capture you know, if it was press pills, adolescent, maybe it's the age. It's a hard question. Wish I could make it easier. Again, I think, you know, we were using these PDMPs before. We knew exactly what was prescribed. It's very easy to capture that. Now it's very hard to tell. We can capture like treatment episodes later on if we're lucky enough to have that data. We can capture buprenorphine prescriptions. You know, but sometimes they're used for pain, as we were discussing before. If we're lucky, we can get methadone, although sometimes that's often very simple. That's also not kept in the same data sets as PDMP, and so that's hard to ascertain. I think it's making our collective jobs a lot harder.
There's a couple online questions, and I just maybe summarize. I think there was a question about your thought from a policy perspective about federal drug regulation. And I'm assuming this means with respect to access to pain medications and your thoughts on, and in particular, like maybe what you're seeing in the ED from patients, because I think Dr. Bonner maybe would also comment on this as it relates to weaning people, or what are called forced weans. I mean, I think it's a separate question that you authored on, maybe you could comment on, but just your impressions on access to pain medications and the importance of this as it relates to your discussion of overdose.
Do you mean as far as for patients that are prescribed chronic opioids?
That's
as an
correct.
example?
Yes. Yeah.
Very difficult. I mean, there's been a sea change in how we treat acute pain. I mean, I think that in the past several years, we've just plummeted our prescriptions from, at least from the ED. Again, a lot of the post-surgical work that many of you in this room have done, we're plummeted our prescriptions post-operative, at least in many cases. But we're left now with a population that, you know, you can call it legacy population, or, you know, it's kind of treated historically, that was still on high doses of opioids. And it's extremely tough for that population, because what's been happening is that it's not about regulation, but it might be that their physician retires and then a new physician comes along and they have no interest in prescribing, or they might want to pass it on to primary care, and primary care has no interest in picking up that prescribing. I will say anecdotally that, anecdotally, our system through the B Corp program, we really did try to emphasize tapering down on opioids as best as we could. We take the very, very slow approach. People that have been on it for years probably need a couple of years to taper down. But what we found is that the majority of patients do better. That the opioids were just masking other symptoms, whether it be depression or anxiety, it's causing hyperalgesia, and they tend to do better. So I know it's frustrating for someone that wants access to their opioid to continue, but I think that the practice and the evidence is changing around that. I just think we have to be really patient-centered and make sure that we're not hurting people in the process. And the worst case scenario would be with like tightening up this, would be that someone would go to the illicit market to get their opioid and then overdose. So we have to be extremely careful about that.
I mean, I mostly can speak from the perspective of the ED, and certainly I feel like there's been a lot of, pressure, even regulatory pressure on the acute prescribing. Certainly in the state of Michigan, a number of years ago, there's now regulations in place. We're restricted to 3 days of acute pain prescribing. I don't know what it's like in the state of Michigan, if there's sort of level of regulation around that. I certainly see at times in the ED, like the problems related to titration off chronic opioids. I mean, a lot of those patients end up at times coming into the ED, and it's challenging population to help for the reasons you give.
Immortal person time bias, everybody's favorite topic. So, this area of work on for patients who have been on opiates for a long time for chronic pain, whether they benefit from tapering or not, there's been about 15 or so studies on this topic, observational studies and health records data, and definitely a developing narrative of the practice is harmful, that tapering patients is harmful. They're dying by suicide, they're dying by overdose. It's actually an incredibly difficult problem to study if you want to make causal inferences, because when you're measuring a treatment that occurs over time, and a taper is something that's occurring over time, events that occur during that same time, you can kind of count the wrong way, either count it as being related to the taper or count it as not related to the taper, depending on what choices you make. We did a study with Optum data we being Mark Rochelle, who you mentioned, who's also at BU, and I and some other colleagues with Optum data, where we used some statistical methods that address that specific question. What we found was basically null results, that for patients on stable long-term opioid doses, tapering off or discontinuing had no to very small effects on risk of overdose and suicide. I think what's important in that is that the hysteria of like tapering is always bad and we're harming patients by doing it. I think that message is wrong and based on really flawed data. But also the idea of we are saving lives by tapering patients, also not at all supported by strong studies, right? So if the whole goal of tapering, and there are a lot of other goals around improving pain care that are in there, so it's not to take away from that, but if the goal is, and the reason why you're starting on the taper is to, because you think they're at risk at overdose, there's no evidence that that taper will address that risk for any one of, potential reasons for that.
Maybe more of a request for you to sort of talk a little bit about Medic. Many people won't know what Medic is. And the work you've done is related to naloxone and the buprenorphine education. I just want maybe just a little understanding of maybe how that's gone, the impressions of the physicians you've worked with across the state, and kind of where you see next steps, and maybe you could just tell people about the work that you're doing to try to start to measure.
Yeah, I'm happy to. I mean, it's certainly not just my work. It's a lot of people's work, a lot of people in this room's work. And it's a partnership with many here at the university too. The Opioid Prescribing Engagement Network has been a big part of this. Started with some pilot money from the state in 2019, 2020, where we partnered with about 10 emergency departments across our state to begin to build these programs around harm reduction. The emergency department really focused on naloxone. And it's got a lot of challenges. You think it's such a simple thing, you could just switch. But the reality is there's a lot of sort of processes that underpin those kinds of programs. You got to collaborate with how does this work in pharmacy? How does this work with nursing? There's a lot of education and training to figure that out too. And we sort of slowly built that program over the years. We're up to about 40 centers. We've distributed about 6,000 kits of Narcan to this point. And we're gradually building it into our this Medic structure, where we have some incentives in play from a payer and insurance company around meeting some targets around naloxone reduction distribution too, which we're going to implement next year, and some data collection around that too. So I think some of the observations I shared earlier, I'll just bring up again. I mean, I think when we started this work, there was a little uncertainty. There is some case to be made around this, but it's different now for sure. Noticeably, people are. I think there is a tipping point, at least in the ED setting, around this is our problem. These are our patients. To your point around the fact that it feels like you have tools that you probably didn't have before, I think is making a difference too. When you begin to understand some training around using buprenorphine, for example, and also naloxone, like you have something you can do to make a difference. And I think that's showing, and that's where I'm, optimistic too about what we can do.
I just have to give credit to the emergency departments around the state and probably around the country that throughout COVID, despite the fact that I don't think there's any part of medicine that was more disrupted than the emergency department, you just kept going. It really incredible how people could have made excuses throughout, and just no excuses, just a spirit of willingness, and it's really blown me away. And I feel really fortunate to have the emergency department physicians across our state doing all this work, and all those nurses who really did all that training. So it's been really cool to watch.
Scott, I know you are also a telehealth provider for patients with opioid use disorder. And I'm wondering, I feel like a couple of years ago, there was a sense that like this could be the solution to a lot of the access problems, particularly in rural areas. I'm wondering if you can comment on your experiences with that, where that leaves you with feeling like it's a solution. What are the barriers? What might it, what is their potential for achieving, and where will it not fully do what it could potentially do?
Yeah, thanks for the question. So last November, I took this role as research director for this group called Bicycle Health. And it's a medical group. It's operating in 32 states right now. It's for profit. It's VC backed right now. And it's been a very interesting experience. I came into it very naively. I thought that's probably fairly straightforward. Like you just see the patient on the computer and you provide the prescription and that's it. But it's obviously much more complicated than that. So to be in the program, you have to be 18 or older. You have to have access to technology. You have to have a smartphone and internet. You have to have a safe place to store your buprenorphine. And we don't provide the buprenorphine. You have to be able to get it from a pharmacy. So already that's a fairly high bar for a lot of patients. I think there's there's a few categories of patients that are served. One was that they were already in an in-person clinic, and this just happens to be much more convenient. So that I think that's one category, and that's a net neutral, right? It's not adding capacity. The second is for patients that truly did not have access before, like more rural environments. We have a lot of patients that are in more rural environments that truly did not have another option. The third are for patients that did have options, but they were just too scared to engage with them. They didn't like the stigma of going to a waiting room. They didn't want to admit it to their primary care physician, as an example. And so this gives them an opportunity to do that. There's another, about 40% of the patients are self-pay, 60% are insured. The self-pay patients, the rate right now is $199 per month. And that gives you as many visits as are necessary with the prescriber, group therapy, peer recovery coaching. But that actually is cheaper for some patients than purchasing insurance or illicit buprenorphine. So it's been able to remove this driver of purchasing illicit buprenorphine, and we hope subsequently diversion. The patients that is not good for are clearly the most vulnerable. If you don't have a place to live, you probably don't have a safe place to store your buprenorphine. So that's been a challenge. Again, if you don't have insurance and you can't pay the monthly fee, you don't have access, which is a real problem. And then I also just against my grain is the silo effect, where this is something completely separate than your other medical care. It's not in the medical record. The only way that your other providers might know about this is if they look in the PDMP and they see a prescription for buprenorphine. So the way I look at it is not the be-all end-all solution. I think that there certainly is promise. I think there's a large number of patients that are now being served that weren't before. But I guess the bottom line is it's not everything. But I do believe it's a net positive. Otherwise, I wouldn't stick with it.
Yeah, thank you. I have another question for you both. Stigma is such a fundamental problem or fundamental contributor to a lot of the problem here and a barrier to a lot of the solutions we could enact. I think of the emergency department as a place where patients particularly have historically reported experiencing a lot of stigma, perhaps in part because that was often the primary place they were getting care, but nonetheless, that was a place of where stigma is common. And my sense is that there's been a lot of improvement. So I'm curious for you both kind of what you've seen as an improvement and what you think has worked or not worked in shifting particularly medical system stigma towards patients with opioid use disorder. And Keith, maybe I'll have you go first this time just to change it up.
Sure. Yeah, I mean, certainly I think for one, I think it's hard to measure what stigma is. So it's just an experience, of course. Definitely agree. I think we're in a different set of circumstances than we were tracking back whatever number of years ago. I do think like solutions to stigma ultimately just begin with yourself. I think if you want to begin to change your work environment, you got to model it. You got to be the one that changes your language, that shows compassion, that cares for patients with opioid use disorder, just like any other patient population, and be that model for change, and sort of build the ability for a unit, a group, a department to likewise change as well, create the conditions for that to happen. And some of that is education, some of that is probably somebody in your group has been affected by opiate use disorder, allowing people to share their stories in the ways that keep them safe. And things change. And I think part of it too is just, we've talked about this, you have tools now that you didn't have before. And I think some of stigma in the past was a bit about guilt and not being able to actually do what you feel like you should be able to provide, which is good care, because you didn't have the tools to do that. There remains challenge in the emergency department. Like that setting is stressed, as I think Chad was alluding to. We usually are not seeing patients on their best day. There are structural and process challenges all the time. And so those challenges will remain. But I do think we're in a different spot than we have been in the past with how we think about caring for patients with opioid use disorder. I don't know what you'd add.
It's great. No, very nice answer. I don't have a lot more to add. I feel I still perceive it. I still think that there's staff that does have stigma. A couple of times I've just privately taken someone aside and said hey, what's going on here? And sometimes it's something that's kind of deeper, and they had bad experiences, and you kind of get to the bottom and say look, we're trying to do a better job for our patients right now. So it takes that, but I think it's ultimately like what you mentioned, it's the modeling. This is what we do. This is what we talk about it. We're rolling out this Suboxone program. We're rolling out this harm reduction kit program, rolling out this naloxone program. And it gets people talking about it. And then they realize that there are tools. And I think that that's the ultimate way to combat it. I'm also, you asked about optimism, or someone in the back asked about optimism. I think the trainees these days are amazing and really do get addiction. And it's become something where when I was in training, we never even talked about it. And now it's on the forefront. And I think there's hope for the future from that perspective.
I'm looking to Kim and Kate. Any last calls for remaining questions? Okay. With that, thank you so much to our guests. Thank you all for attending. A special thanks to the teams at the Office of the Vice President Research, Michigan Open, Michigan Opiate Collaborative, the Government Relations, particularly Beth Sprang and Abby Hall for coordinating today's event. If we could give a final clap for our presenters. Great, and that's it. I think, are there still refreshments outside? Yes, okay, so still some refreshments, and hopefully we can all talk some more. Thank you.